Hello, my name is Lauren Clark, and I am a student physical therapist from the University of St. Augustine of Health Science. I would like to thank you all for coming today. I'm going to talk about a patient I recently evaluated who is a 27-year-old mesomorphic female whose chief complaint was centralized low back pain resulting in lumbar hypermobility second to postural abnormalities and thoracic hypomobility. According to Biazel 2010 in the Journal of Joint Manual Manipulation Therapy, spinal joint hypermobility is defined as an unstable joint that has normal physiological load but moves through an abnormal excessive range of motion. The purpose of this presentation is to present data to show what contributed to her hypermobility and treatments to help monitor and prevent it from occurring again. The patient's problems occurred through an insidious onset, and she did not see a physician prior to evaluation, nor were there any imaging done. She did report some self-treatment strategies such as taking Tylenol, ice, and self-manipulating techniques to crack her middle and lower spine. Her centralized low back pain increased and was most limited in backward bending and side bending to the right and left. The numeric pain scale is used to quantify the patient's chronic pain. The NPRS is a scale from 0 to 10, 0 being no pain at all to 10 being the worst pain imaginable, resulting in the emergency room. The scale is validated by Renana et al. 2019 in the Pain Practice Journal and has good reliability. The patient's pain remained at a constant and dull pain of a 3 out of 10. Sitting, standing, or running for a long period of time made it worse, resulting in a 7 out of 10 on the pain scale. In addition to Tylenol and ice, lying down on her back with her legs up would relieve the pain to a 0 out of 10. Her occupation was a student, which aggravated her lower back pain as the day progressed. She denied having any radicular symptoms despite describing knife-like localized pain periodically when she begins to run. No paresthesia or numbness was reported during the assessment. Her past medical history was unremarkable other than she presented with an increased lordotic curve since she was 14 years old. Her prior level of function was that she enjoyed hiking and running. However, her pain and spasms increased as she tried to complete these activities. Her goals from physical therapy were to return to hiking, running long distance, and to stand or sit for long periods of time throughout the day with no range of motion or pain restriction. The Oswestry Low Pain Disability Questionnaire is an outcome measure that I chose to use with this patient to measure a patient's permanent functional disability. The ODI was validated by Johnson et al. In 2013 in the BMC Musculoskeletal Disorder Journal, and it provides excellent sensitivity and specificity. The subjective questionnaire consists of 10 sections with a total score of 5 in each section. The total number is then divided by 50 times 100, which will equal the percentage determining the severity of the disability. My patient presented with an 18%, which would fall under minimal disability, being that 21% is the cutoff for moderate disability. She has increased pain with some aspect of her social life, such as running, hiking with friends, and prolonged standing or sitting. Moving on to the objective findings of the patient's examination, she presented with an increased lordotic curve in her lumbar spine. I had her perform active range of motion, which she presented with limited backward bend with pain, limited right side bend with pain on her left side, and left side bend limitation with pain centralized in the low back. Her forward bend was relatively normal with no limitations or pain. Muscle palpation revealed that she did have an increased muscle tone in her rector spinae muscle on the left side. I performed passive range of segmental mobility to her spine and found both hypermobilities and hypomobilities. The hypermobilities were found at L2, L3, and L3, L4 segments. The hypomobilities were found at T10, 11, T11, T12, and T12, L1 segments. Neurovascular tests were performed and were found unremarkable. The lower quarter assessment revealed tightness to her iliopsoas muscle. No imaging or diagnostic tests were performed as the patient never went to the emergency room for her problem. In addition, she had a positive supine to sit test on her left side, but when it was performed again, she presented with a negative supine to sit test. The physical therapy diagnosis for this patient is facet capsule hypermobility, or using the International Classification for Function, we would classify this patient as low back pain with movement coordination impairments. Her physical therapy goal was set at 4 weeks, and her long-term goal was to restore normal range of motion of back bending and side bending without pain to allow her to sit or stand for long periods of time, to hike with friends, and run at least 1 mile distance. The following is a list of impairments with evidence-based research to back up the plan of what the interventions are going to be for each impairment listed in hierarchical order. The first impairment was facet hypomobility in her thoracic spine, and for this impairment we are going to perform spinal manipulation. In a study conducted by Sung et al., 2014, in the Journal of Physical Therapy Science, spinal manipulation is found to increase range of motion and decrease amount of pain and disability. For functional outcomes, we need to address the hypertonicity of the erector spine and muscles, so we are going to perform soft tissue massage and myofascial release to help treat those muscles. To address her tight iliopsoas muscle, we are going to stretch them. According to Dinakaran et al., 2018, in the National Journal of Physiology, Pharmacy, and Pharmacology, contract, relax, antagonist contract of the iliopsoas combined with hamstring stretching helps to increase the flexibility of the hip flexor muscles to help relieve low back pain. For the patient's increased lordosis and anterior pelvic tilt, we are going to provide patient education and postural cueing to help her achieve neutral alignment. Next, there was facet hypermobility in her lumbar spine, and for this impairment, we are going to perform transverse abdominal holds to help stabilize the spine. According to Kim et al., 2013, from the Journal of Physical Therapy Science, TA holds help prevent and treat patients presenting with hypermobility. To target her weak lower abdominal muscles, we are going to strengthen her rectus abdominis, obliques, and transverse abdominis. According to Cho Rung et al., 2018, in the Journal of Back and Musculoskeletal Rehabilitation, strengthening core muscles through assisted sit-up exercises can help reduce pain and strengthen core muscles to provide more stability in patients with low back pain. Finally, for her decreased range of motion and limited function, we are going to use neuromuscular reeducation by performing mobilization of movement to the lumbar spine. Her prognosis is good because she is young, active, and presents no red flags from her past medical history. Even with her hypomobilities, limited range of motion, and muscle guarding, I believe she can make a full recovery. According to Atlas et al., 2011 from European Spine Journal, lower back pain in the United States is estimated to be about 17% of the population. Over 60% of patients will experience low back pain at some point in their lifetime. Many of these patients opt for surgery instead of conservative management, even if the results are proven to be beneficial for conservative management. It is important to isolate impairments as a physical therapist using evidence-based practice to address each one of them with the correct interventions to ensure success of patient goals. Thank you for attending my presentation, and I would like to take any questions at this time. Thank you.